sharing. Okay. Good morning, Janine. Good morning, Largo. I've been trying to call Melody at Largo to see if we can make a phone connection. If someone at Largo could call 813-323-5447, we can establish a phone connection. So 813-323-5447. Please call from Largo before we get started here. Hang on. Okay, we're going to go ahead and get started now. If someone from Largo could please call at 813-323-5447 to get a phone link, we'd appreciate it. We're going to start out with our case from today. The patient is very interesting. Her name is JG, and she is 85 years old. She lives on Davis Island here in Tampa and was referred to our clinic by her concierge physician for concierge cardiology. Well, this is interesting link of concierge cardiology and concierge physician. Hang on, we just heard from Melody again, and she's going to call Largo and get someone to call in. Melody's going to do that. So patient, her son lives in Manhattan and is an executive. He was an executive here, he's an executive there now. Daughter is a local TV newscaster. So these are pretty visible people who have a mother that they're pretty committed to and who's had a lot of problems. The patient's very complicated medical history, is seeing a hematologist, pulmonologist, cardiologist, her concierge physician, several ENT doctors. She has been established as having chronic diastolic heart failure by cardiology and has combined myelodysplastic, myelodyspproliferative disease with anemia and low platelet counts. She weekly has gotten RBC transfusions as well as platelet transfusions frequently. She has bouts of shortness of breath and dizziness attributed to recurrent bilateral pleural effusions, left greater than right, with trapped lungs from frequent thoracenteses. Her symptoms tend to improve after she's had drainage of her pleural space on the left side with a Pleurex catheter, our home health nurse. She has to frequently go to the hospital because her hematocrit will drop. The fluid is pink tinged, sometimes frankly bloody, but for the most part has been pink tinged, but is not straw colored. So I think with her low platelet count, it's always a traumatic event to drain fluids, and frequently the pleural catheter gets obstructed, then they have to open it up with TPA, then she gets frankly bloody fluid, then her hematocrit drops, then she has to get a transfusion, her platelet count drops, then she's got to get platelets. So it's a vicious circle that keeps going around as a cycle and can't be stopped at this point. She also has had voice hoarseness, which she's extremely annoyed by. It troubles her in her daily activities, phone calls, contact socially. She's had 2 ENT consults and no one's been able to determine the etiology of her hoarseness. She denies any chest pain, palpitations, syncope, falls, edema, orthopnea, fever, chills, recent illness, fatigue, or changes in her appetite. She has what's called a trapped lung, which develops because of pleural space inflammation, resulting in development of fibrous membrane that impedes the lung from re-expanding. This creates a negative pressure involvement in the pleural space filled with fluid, and that gets the pleural effusion, so it becomes recurrent, and so this goes over and over again. She's not had a pneumothorax. Here's an example over here of a trapped lung, where you can see an air fluid level, or fluid level. You can see a fluid level, you can see the lung, you can see some atelectasis in here, and that just keeps going on and on as you keep tapping. Patient was presented to me as a challenging, demanding patient with a highly engaged family with a desire to have individual personal cardiac care as well as the family practice care that she's getting from her concierge physician for a medical condition that appears to be irreversible. The concierge cardiac care is a service that's offered that offers full access, including home visits, cell phone contact, immediate follow-up in the office, contacts on Fridays, which is a day our clinic's not open, and very high maintenance medical demands, of which it appears in this particular case that they are insoluble, and it just have to make the patient more comfortable and make it more convenient for her to get transfusions of RBCs or platelets or get her chest tapped. Doesn't seem to be any answer to this vicious cycle that she has. So she came to the office on Thursday. I did not see her that day. She just came for the pre-office visit echo. And so I had a pre-office visit echo that I could sit back and look at, not having seen anything other than this about this patient, other than some stuff about her being demanding and being a problem patient and wanting more engagement. Basically, this is the information I had. And it looks like from what I saw, and this is what the tech wrote down, that she had LVH and posterior wall thickening, normal LV contractility. So that's interesting. Well, they said she has diastolic dysfunction, so that fits with that. She has a normal sinus rhythm, which is interesting, and severe mitral regurgitation. Usually patients with severe chronic mitral regurgitation develop atrial fibrillation. She has a markedly enlarged left atrium, but is not in atrial fibrillation. So that's a good sign. Certainly she would be in a lot of trouble in terms of diastole if she had atrial fibrillation. She wouldn't have the atrial kick. And so her RV systolic pressure is very reactive and very elevated. She has jugular venous pressure that's elevated. It's obvious later on that she has ACV that can be seen in moderate tricuspid regurgitation. She's got normal aortic valve, normal aortic root. And so the questions I have from looking at her echo are her problems appear to be severe mitral regurgitation, causing her hoarseness and causing her pleural effusions, which then get tapped, and then she gets anemic because of low platelet count and because of traumatic bleeding and the pleural fluid going from straw-colored to pink to blatantly red. Is she a candidate for a conservative surgical procedure that's limited called a mitral valve clip, where you access the mitral valve through the septum and you put a clip in, which is called the Alfieri procedure when it was done surgically, and reduce the mitral regurgitation by as much as 80%. Who can clip her? Would they turn her down as high risk because of her platelets and anemia? How can I get answers to these questions? Because obviously my interest would be coming up with a unifying theory of what's wrong with her, coming up with some way of interrupting this vicious cycle and being able to get everybody engaged in doing something that would be definitive. So let's see how I tackled these questions. So Didier Lemay is the gentleman that you've all seen online here because he's at New York University. He frequently does robotic mitral valve repair on our patients here in the hospital about 3 days. The last one he did was 86 years old, and he is actually the first mitral valve robotic repair was done by him, and he specializes in that. He's also done cardiac tumor removal for me, for one of my other patients, and he's done multiple mitral valve repair procedures robotically on my patients. And you can see he has superb training. So first thing I do is call Didier, and not because this lady's a candidate for that, but I need to find out, who is it at their place that does the clip, and what's the level of experience. And he recommends Dr. Matthew Williams for the mitral clip. So let's see what we know about Dr. Williams. And here's Matthew Williams. This is remarkable. He's done 2,500 TAVRs. Wow. I mean, I think at Tampa General we've done 200. Northside has done maybe 60 by now, and he's done 2,500. So obviously they were the first one in the United States doing TAVRs. And so I think that's remarkable. He does the mitral clip. The other remarkable thing about him is he's completed cardiothoracic surgery and interventional cardiology fellowships. So he's a cardiac surgeon and an interventional cardiologist, as well as a cardiologist. And so, and he's done general surgery as well because it's a prerequisite for cardiac surgery. So that's very interesting that he straddles both fields. A hybrid physician, which is kind of interesting. So my team said this would be interesting if we get in touch with him, see if we can do that procedure, and so we did. And he was not available, and unfortunately, everyone was at the ACC, which was meeting in Washington, D.C., so we were able to get in touch with his PA, who was actually sitting on a panel at the ACC giving a presentation. And so we talked to him after he got off the panel and said we'd like to create a mini webinar with the patient and with the echo, which is the only information that we have about the patient. We'd like to put that together and have that available for Dr. Williams to review and for his colleagues to review to see if she's a candidate for a mitral valve clip. If she's a candidate for a mitral valve clip, then we can send her to New York and we can move on. We can also gather further data, for instance, cardiac CT to see if she has coronary disease. If we could avoid doing a cardiac cath, that would be very helpful. TEE, we decided if she needs a TEE, they could do it there. MRI is available here, and we can do an MRI, which is equivalent to a TEE for me, but perhaps not for Dr. Williams. And so, and apparently we talked to the team there, and they're not very successful at cardiac CTs, and the success rate of getting a good, decent coronary anatomy on a cardiac CT at NYU is about 20%. And so a tribute to the fact that the insurance companies usually don't pay for it, so nobody does it, so nobody can do it because they don't have the experience. And so we made this video with the patient and with Dr. Williams' PA. And so the next part is to show the video. We shared the video with Dr. Williams, shared it with the family of this patient, her daughter and her son. And the patient had access to the video too, so she could watch it again to make sure she has all the information that she needs and to make sure that the dialogue is complete. So the next step is we're going to show this video. I'll start your record. Can you see the screen, Michael? Yeah. Okay, great. So we are with a patient whose name is Joanne Gallardo. Joanne Gallardo. How old are you, Joanne?
85.
Joanne is 85 years young, and Joanne has a history of recurrent pleural effusions that require frequent tapping. She has a myelodysplasia syndrome and has to have blood delivered transfusion weekly because of that, and she keeps accumulating a left pleural effusion with thoracentesis, and she has also a right pleural effusion. She has severe mitral regurgitation, which we think is the origin of her pleural effusions. She has dyspnea on exertion and has been having chronic heart failure because of mitral valve regurgitation. And she has normal left ventricular contractility, and we're going to show you her echo now. Her current medications are those geared towards congestive heart failure, where she's taking carvedilol 3.125 BID, Citracal, famotidine 10 milligrams, 1 tablet daily, Flonase, folic acid, lisinopril 2.5 milligrams daily, melatonin, mirtazapine, Mucinex, Prolia, Restoril, Tessalin pearls, and torsemide, 10 milligrams orally. She runs a systolic blood pressure of 89/61, but she's a small lady. She weighs 104 pounds. Her heart rate is running around 90, and she has a normal sinus rhythm. She is not in atrial fibrillation. She has a normal sinus rhythm. She is here for evaluation for mitral valve clipping, and so we're going to examine her mitral valve to keep that in mind. So we have the only piece of data we have at this time is her echocardiogram, which was a transthoracic echo. So we thought we would show that first before we go on and get more data. If you feel we need a coronary CTA to make sure she has normal coronaries, we can do that. If you feel she needs an MRI, we can do that as well, or a TEE. So now we got this. What's that?
TEE.
Yeah, we actually we have quality MRI that the MRI is actually equal to, if not superior to, the TEE. So, and we use a GE state-of-the-art echo machine, and actually this echo is better than the TEE as well. So, so we can give you much better data. We get a CT for the coronaries. We can give you MRI for mitral valve structure. That would be a lot more useful, I think, than the TEE. But so we're now looking at her mitral valve. We see some calcification in the posterior mitral annulus, but the valves look like, the leaflets look like they're moving pretty well. You can see the chordate, and you can see the papillary muscle. See, the aortic valve looks fine. There's a little calcification there, but good opening, and normal left ventricular contractility, which is great. And so we're going to go on and give you some more pictures here. You can see she's in a normal sinus rhythm, which is a surprise. She has a very large left atrium, and you can see the ratio of the left atrium to the aorta. You can also see some of the right ventricle. It doesn't appear to be enlarged there. We're moving on to get you some more pictures. And so here's the M mode, which is not very instructive. She doesn't have any mitral stenosis, obviously. She doesn't have any aortic stenosis, obviously. Transverse left ventricular contractility appears to be normal. No pericardial effusion. And you can see some of the right ventricle up there in the right ventricular outflow tract. The aortic valve appears to be normal. We're seeing some of the jet of the mitral regurgitation in the left atrium. And we'll give you some better images as we move through. The aortic valve is moving quite well. The tricuspid valve leaflet does appear to be normal. We'll see some TR when we get to it. Here are the mitral valve leaflets. You can see both of them. You can see some calcium at the tip of the chordae. You can see also some posterior mitral calcification. The aortic valve's opening well. And as we move on, we can see that that's a central jet that's coming across the mitral valve and going posteriorly, and it's going all the way to the end of the left atrium, and it's a wide base jet. And now you can picture the calcification in the posterior mitral annulus well there, as well as some anterior annular calcification. Anterior leaflet looks very mobile, as we see there. The posterior leaflet is not seen as well in this particular view. Left ventricular contractility again is normal. Mitral regurgitation going to the posterior wall. And right-sided tricuspid regurgitation, which I believe is a secondary event, not a primary event. I don't suspect there being any tricuspid valve disease. And you can see why she'd be blowing off on the right side, because she's got a RV systolic pressure of 67.30, 77 RV systolic pressure, 77 millimeters of mercury. But the right side looks functional, and I see right-sided contractility, which is excellent. You can see some diastolic dysfunction, and LV contractility, RV contractility RV size, left ventricular, left atrial size. Left ventricular contractility, again, is well preserved and probably a little hypersystolic. Mitral regurgitation is well appreciated in any view. Left atrial enlargement again. Tricuspid valve appears to be normal. And there's the tricuspid valve, there's the mitral valve, left atrium, right atrium is a little enlarged from the TR. Right ventricular function appears to be normal. There's a nice view. You can see the interatrial septum. It's bowled a little towards the right. Pulmonary veins are prominent and dilated. There's our jet or mitral regurgitation. This particular plane, the jet doesn't look as large as in this plane because it fans out in a different plane. There's her TR. And inferior vena cava is enlarged. She has normal laboratory values, which we'll look for here in just a minute. And here's her strain echo. And you can see that there's decreased strain in lots of the heart, which is correlated by Dr. Tom Merrick, the decreased strain globally as well, and especially on global longitudinal strain, which in her the average is minus 17.5. It's just down a little bit. It's not very bad. Minus 17.5. Normal should be about minus 19 to 20. And so that actually predicts left ventricular dysfunction. I believe she's a non-smoker lifelong. And she's had some hoarseness of her voice recently, which is probably secondary to the recurrent laryngeal nerve. Her BMI is 19.69. And she has some thrombocytopenia and also some anemia. Little osteoporosis. Had her flu vaccine in the past. Yep. And we'll have some more information on her in just a minute. We've got a hematocrit, runs about 25.6. And we've got a platelet count that is estimated decreased. It's 57,000. We've got normal urinalysis. We've got a creatinine of 0.731, which is normal. Potassium 3.9. ALT is 47. AST is 29. Those are normal. Alkaline phosphatase is normal. Bilirubin is 0.5, which is normal. Albumin, 2.8. That's low. Okay. Protein, 5.2, which is low. Calcium, 7.9, which is low because the albumin's low. The B-type natriuretic peptide is 147.6, which is elevated, but may be normal for her age and sex. Troponin is negative. She has recurrent left thoracentesis with residual left pleural effusions. She has some chronic multi-level thoracic and lumbar compression fractures. She has a catheter. She has a catheter for her pleural effusion, and it's drained every couple days. That's secondary to congestive heart failure.
About 300 cc's.
They take 300 cc's out. So if she could, she's had a nuclear lung perfusion study which is negative for pulmonary emboli. And recurrent chest x-rays which show her bilateral pleural effusions. Cardiomegaly, of course, on her chest x-ray, but contributed to by her left atrial size. Platelet count, repeat, 43,000. Hematocrit, 28%. She is O positive, is that correct?
Yes.
She's O positive. And I don't see any other laboratory reports. There's a 34,000 platelet count. She's a very cooperative lady. She's of sound mental status. She was sitting in here reading the newspaper. She's very bright. She's very fast. She moves around on her feet very rapidly. Looks like she might be from New York or something.
No, it's just suffering.
And so she certainly would appreciate any progress that she could make. And she is a very sharp lady, very sharp lady. And I have her EKG, which shows remarkably a normal sinus rhythm. She's got heart rate of 99, PR interval 0.122, QRS duration 86 millisieverts, 86 milliseconds, QTC interval 404, axis is 68 degrees. She has some left ventricular hypertrophy, a wall thickness of the septum of 14 and a posterior wall of 13. Ejection fraction is calculated at 62%. RV systolic lately is calculated 86 millimeters of mercury. And I think we've got it pretty well summed up.
Okay.
So we have a recording of this. With any questions you'd like to ask the patient?
So do you have any family here,
I had
Joanne?
a son in New York City who works right in Manhattan. He's with, actually he's vice president of Discovery.
So that sounds really convenient. One, a son there, and two, sounds like they got a good Discovery card.
Yeah.
That's Discovery Media,
Oh, Discovery Media, okay.
the TV.
Okay, we just dropped out on our conversation, and so because my telephone battery ran out, and so we're going to end this recording, and then I'm going to contact Michael again in a few minutes from my office, and we're in the core laboratory right now. So I'm going to So let's go back up on our slides. And so basically we created this video in order to access Dr. Williams and his team. And actually for the mitral clip, two people in the team have to sign off on the case. And one of them is an echo expert and the other is Dr. Williams. And so the plan was for Michael to get that recording of the history and information as well as the echo for everybody to review. We posted that online for limited access for Dr. Williams as well as his team, as well as for the patient and her family, and the patient could refer back to it. So this is kind of a new way of moving forward in cardiac surgery and interventional cardiology, and that is the video when the ACC has a meeting and there's nobody available. And so let's move on and see. So the patient came to my office. We made this presentation. She's a very amazing lady. She reads the New York Times. She's very fast thinking. She wants to move on. She wants to get something done. And she is moving around getting things done. She's going to go over and get her platelets checked and probably get type and cross And so she's going to go do that, and she will come back, and so for the presentation, and so that's what she did. And then we made this video together, and with Dr. Williams' PA. So let's move on and see what happened to this woman and how she sort of got sidetracked. I mean, why in the world, is she not going on for mitral valve long before this? And so we've got an echo from a year ago. And so a year ago, she was in this situation a year ago, not as bad as it is now. And so she had normal ejection fraction. Her RV systolic pressure was only about half of what it is now. It was 41 millimeters of mercury. She had severe left atrial enlargement and severe mitral valve annular calcification. But they only said she had moderate MR on that particular study. And you know how difficult it is to quantify mitral regurgitation. It seems that the right side of pressure being elevated is certainly a good hint that there's significant mitral regurgitation, that there's moderate TR, that's another good hint. And then the fact that there's severe left atrial enlargement is an excellent hint. Something's got to cause that. So you say, oh, well, she's probably in atrial fibrillation. No, she's not in atrial fibrillation. So you can't blame atrial fibrillation being a reason for her severe left atrial enlargement. So it looks like even back there, she could have had consideration for mitral valve clip, or maybe at that time she could have had a more significant surgical procedure such as mitral valve replacement. So let's move on, and here's another part of the prior workup, which was this year, and this year was mild mitral regurgitation. Whoops, wait a minute. Mild mitral regurgitation, mild to moderate is what they were reading. Again, they had the left atrium only mildly enlarged, so this varying from reader to reader. And what are you to do if you're the patient's family practitioner? You're just going to look at this and say, well, it doesn't look like that's a significant problem. And so basically the cardiologist had signed off on this lady having diastolic dysfunction and had sort of missed this diagnosis of severe mitral regurgitation, and so they weren't pursuing this. So the ENT doctors were saying, we're mystified as to why your horse, where everybody knows who's a med student, that left atrial enlargement causes pressure and strain on the recurrent laryngeal nerve and causes hoarseness when you get a big, big left atrium. And then the bilateral pleural effusions, obviously looks like they were transidate, not an exudate. And so that also is part of the process of recurrent pleural effusions as congestive heart failure and manifestation of mitral regurgitation. And so somehow it got missed that she had severe mitral regurgitation. And then she had the usual SPEC scan. I call it SPEC scam. And it showed moderate-sized transmural perfusion defect involving the apex and periapical segments compatible with infarct scar. I think that's some left ventricular dilatation, and I think that's apical thinning. And apical thinning basically is very common and actually increases as there's stress put on the left ventricle. So the ejection fraction would drop, and guess what? The ejection fraction dropped from 64% to 55% because of the left ventricular dilatation that takes place with regadenoson or adenosine or whatever the agent was that they used for provocatively to test the heart. And so I think this all is a manifestation of left ventricular dilatation. And actually we've written about transient left ventricular dilatation and dilatation of the apex and how that looks like a defect that's a reversible defect at the apex when in fact it's just apical dilatation and it has nothing to do with ischemia at all. And so this is more manifestations of the same thing. It's not ischemic heart disease. It's left ventricular dilatation during adenosine with the drop in ejection fraction. And so the history of chronic diastolic heart failure hasn't been demonstrated. It was a diagnosis perhaps by exclusion. Certainly she's on the right medications for mitral regurgitation if she's got left ventricular failure. And you should have a hypercontractile left ventricle with chronic mitral regurgitation. And so the fact that her left ventricular contractility has drifted down to 55% would be a reduction of what you would expect. You'd expect an ejection fraction of 75% in this patient, where she's trying to compensate. If you got to pump 5 liters per minute and you've got a 50% regurgitant fraction that's going backwards through the mitral valve because it's not working, then you got to pump 10 liters per minute. 5 of it goes backwards and 5 of it goes forwards, and that gives you your 5 liters per minute. So the heart has to work twice as hard. And so the whole systolic murmur was very obvious. You can hear it on this little lady. She's very thin-walled, chest-walled, very little lady. You can see her CV and AC and V waves in her neck that are very prominent, with a prominent V wave from her tricuspid regurgitation. Good distal pulses. She did have an S3 present. Here's her EKG as read to you. Again, showing sinus rhythm and not a very good reproduction here. And then so we've got an elderly lady with severe symptomatic mitral regurgitation, and she's got heart failure with a preserved ejection fraction. So all preserved ejection fraction heart failures are not diastolic dysfunction. And so that severe valvular dysfunction has to be excluded before that's your diagnosis of the cause of heart failure. And so we discussed with Dr. Matthews of PA. We've sent the video, put it online so it's accessible from a Dropbox. It was reviewed by the group and by the echo expert, as well as by Dr. Williams, and everyone concluded that it looked like from this information that the patient had an 80% probability of being a successful mitral valve clip patient. And so without the transesophageal echo, which they rely on probably too heavily, it looked like this patient had all the hallmarks of someone that could be clipped. And so she's been back to the hospital again recurrently. This time her hemoglobin dropped to 6.4. I think we're losing some opportunity here, and we need to move on and actually set her surgical date sooner. And we actually did that, moved it back a week, so that she, at the last minute, it looks like we're going in to rescue her mitral valve, even though we had more opportunity a year ago, and there was plenty of warning, and it wasn't appreciated. So she's going to get this procedure done, and we're very excited about that. Her son lives in Manhattan, so they're right down the street from the hospital. She's very familiar with New York University, and we were going to tell you a little bit more about mitral regurgitation and about clipping, and so I'm going to give you Dr. Tariq. Dr. Tariq, here you go.
Good morning, everyone. So I just related to the case, I looked up the guidelines which are out there in terms of how the mitral regurgitation is staged, and just to get an idea where our patient stands, considering how symptomatic our patient was and how the echo showed the severe left atrial enlargement and the right ventricular systolic pressure being raised and so on. It was quite obvious that our patient falls in stage D, having symptomatic severe mitral regurgitation. And then I basically looked at what are the indications for surgery in mitral regurgitation. So this patient has primary mitral regurgitation, and he has severe and symptomatic disease, and his left ventricular ejection fraction is more than 30%. So he would, there is a class 1 indication that the patient should be getting a mitral valve surgery, and that's basically it. And then after that, I looked at some of the recommendations that are there for chronic primary mitral regurgitation. And in terms of our patient, she would fall in this category where you have the surgery because the patient is symptomatic and has this chronic severe, and the ejection fraction is more than 30, just like the previous slide. Also, the patient should have a repair as opposed to a replacement when the surgical treatment is indicated, and when the actual primary mitral regurgitation involves the anterior leaflet or both leaflets. I think there were a bunch of echoes from before that showed that the patient actually had both leaflets involved in the mitral regurgitation. And as Dr. Harrison mentioned at the end just now, that after discussion with Dr. Williams, they believe that the repair, they have a very good chance that the repair can be accomplished successfully. So this would also apply to our patients. And the other indication that actually will go for our patient is also having this transcatheter mitral valve repair, which is the clipping. It can be considered for someone who's severely symptomatic, which in our case, if you look at the New Heart Association classification for heart failure, our patient would definitely fall in class 3, class 4 because she's having symptoms all the time and recurrent symptoms, and they only resolve after she gets these transfusions, to only temporarily, or actually after she gets the thoracocentesis and so on. So, and the patient has a severe disease, and she's probably is not such a good surgical candidate of replacement because of the severe comorbidities she has, because of the low platelets, the anemia, and so other comorbidities make it hard for her to have replacement surgery. And so all of these kind of indications go as in favor of why the patient should also have a mitral valve clip with the transcatheter approach. And so that's basically it. And some of this information was mostly taken from UpToDate, and that's based on some of the guidelines by AHA, ACC on the management of patients with valvular heart disease. So that's basically it. Thank you very much. Dr. Harrison, you want to finish it off?
So in conclusion, we're talking about the mitral valve clip. She doesn't have diastolic dysfunction, even grade 3 or 4. And so this is the clip and how it's accessed to the mitral valve by transeptal, and then the clip positioned across the mitral valve. And you can see why it would be needed in cases of a central jet, and how basically that reduces the orifice significantly, and we've got just a much smaller orifice when you look at this compared with the whole mitral valve. And so we can see that the mitral clip has been used by this group in 828 patients, and that's the German registry that some of the people worked in, and basically the data has been good, with the only risk being major bleeding complications, which pericardial tamponade. And so these are the things that we would be considering in this patient because of her anemia and decreased platelet count. And obviously you can see this is a group of very sick patients, and yet for the whole group the mortality rate was only 1. And you can see that the complications can be managed, and there's clip embolization, which was 0, partial clip detachment, which was almost 2%, which is low, in-hospital death, and basically myocardial infarction, stroke rate is very low. Patients were very ill that had this procedure, and the ones that were worse were the ones that had the complications. So I think that this could be manageable in this particular lady. So we're hoping for the best in this, and I thought I would share with you this very interesting case and the very interesting approach to it, where I had never saw the patient before in my life. We looked at the echo, had that the day before, and it looked like it was very encouraging in terms of mitral regurgitation being the primary problem. The patient wouldn't need this concierge approach, but would need a direct approach to intervention. The choice of the interventionist being made very carefully, and using countrywide experts, and then the engagement of the interventionalist, who happens to be a cardiac surgeon as well as an interventional cardiologist, which is amazing, and then the group being engaged by video, and then getting reviewing the video and making the decision. And now the patient is scheduled to travel on Monday, and I think she says she can go by airline, commercial airline. And I said, do you want anybody to go with you? And she said, no, I'm fine. And so she's amazing. And so she'll be on that airplane. Her son will be meeting her at the plane. On Tuesday, she'll be in the hospital. They'll do the TEE. They'll probably do a cardiac cath the same day. And then she'll be getting her clip later in the week. So we're very excited about doing this, and we're very excited about this lady and hope that we can turn this into a good story. So thank you very much for attending. I look forward to next week. Bye-bye now.